The dominant sort of paradigm that we use to risk stratify patients is okay, but actually fundamentally flawed. And the fundamental flaw has to do with the fact that most models of people's risk, so if you try to sort out 100 patients and say these top 25 are the highest risk, these bottom 25 are the lowest risk, etc., those models tend to focus on one endpoint or class of endpoints called event-free survival. So the typical one would be overall survival. So is a patient alive or not? Okay, that's very simple to quantify. It's unambiguous, right? So it's a very desirable endpoint to know. And by and large, it works. But where it breaks down is when people have an appreciable risk of dying from something else. Then those models fail, because what they do is they treat a death from cancer equally to a death not from cancer, and those are of course not the same thing. So what happens is someone who has a very poor survival tends to be labeled high risk. But when they imagine a patient who has 75% of that risk is actually attributable to things other than cancer because of their other health problems, that actually makes no sense, right? Because that patient is now high risk. You would put them in the same category as someone who has a horribly advanced cancer and needs more treatment, and now they're in the same risk pool, but their treatments should be quite opposite from one another, right? So if you don't separate those events, you have no hope of solving it. And this is part of the problem with risk stratification schemes that are focused solely on the tumor, okay? Because at best, they can only hope to explain a part of the problem, right?